Started. Thank you very much for joining us this afternoon. My name is Desmond Banks. I'm an assistant teaching professor here at Boise State University within the School of Public and Population Health. And welcome to our continuing education session today. We are truly delighted today. We're really privileged to have the expertise of Ms. Chelsea Kennedy, who's an attorney at CHC Legal and also an expert in all things policy here within the state of Idaho. As you can see, her presentation today is titled The Impact of Medicaid Legislation and Public Policy on Public Health in Idaho. So without further ado, Ms. Kennedy, take it away. Thank you. And also, guys, during this presentation, Ms. Kennedy has given us permission to interject with questions. So in addition to questions that you may have at the end, please feel free to put anything within the chat and we'll pause during that time of the presentation to give you the floor. So please put any questions that you have into the chat, but please you don't feel reserved to hold those to the end. Anytime a question comes up, just put it into the chat and we'll read it off. Thank you very much. Ms. Kidney, the floor is yours.
Thank you, Dr. Banks, and thank you everyone for joining us today. I will caveat, I appreciate the accolades that Dr. Banks provided, but I am no means the state expert in all things Medicaid and policy. I will say that my prior legal experience has lent me some more exposure than maybe most in the world of Medicaid. And I am particularly interested in this topic because of the clients that I serve. So my name is Chelsea Kidney, like you said, and I work for CHC Legal. We advise a number of provider groups, including several federally qualified health centers. And if you don't know what a federally qualified health center is, I would love to expound on that. They are a wonderful service. They provide healthcare to anyone, regardless of their ability to pay. And they create the backbone of healthcare here in Idaho. So we're truly honored to help them, the federally qualified health centers here in Idaho, as well as in Oregon, Washington, Utah, Arizona, and I think in Wyoming as well. But really, why this topic matters is in every state where we work, there is a population that is entirely dependent on Medicaid and Medicaid expansion. And with the current legislation coming down the pipeline and going to be implemented, as we'll talk about in this timeline, there will be a significant percentage of that population that will no longer have access to health care. And we know, and this is the part where I have to caveat, I'm not an expert in social determinants of health, but there are plenty of studies out there that indicate access to healthcare is going to be one of the highest social determinants of your overall health. So if you're able to get preventative care, routine screenings, you'll have a better outlook on life. You'll report being less depressed. At least that's what some of the studies have shown. So anyway, without further ado, let's get started. I wouldn't be an attorney if I didn't come with a disclaimer. Mostly, I'm not here to provide legal advice. If you have specific legal questions, please feel free to reach out. I'd be happy to talk with you about how we can connect you with the right services. And this presentation is not legal advice or professional advice. Okay, so then let's talk about what our agenda is. What's our roadmap? I want to start with the big picture. And the big picture started with the One Beautiful Bill Act. And I'm a little astounded by the One Beautiful Bill Act for a number of reasons, and we'll talk about those. But within that context, we have to limit our discussion today on four main areas that are going to impact Medicaid. The first is the eligibility determinations. Next is cost sharing. The next is the retroactive application. And then what you're all here to discuss today, which is the community engagement. Lastly, we're going to tie this all back together and talk about how it's going to be rolled out in Idaho and the impacts that we will see or expect to see here locally. So let's talk about it. The One Big Beautiful Bill Act, as we've all heard, OB3, it doesn't matter how many times they try to rebrand it. I can't think of it anything other than that. At one point in time, the executive branch realized that the One Beautiful Bill Act did not exactly land well as far as a branding. So they have rebranded it, and it is now called the Working Family Tax Cut legislation. So if you receive any informational materials from CMS, they will call it the Working Family Tax Cut legislation. Apparently that sounds better. Maybe it's more palatable. I disagree. But whatever you want to call it, the main part of this is that it was not a healthcare bill. It was not specifically targeted for healthcare, and yet it is going to have one of the largest impacts on healthcare that we have seen in the last 20, 30, 50 years, specifically because of the impacts it's going to have on Medicaid. So those changes to Medicaid that we're going to be talking about today, again, eligibility determinations, cost sharing, retroactive application, and the community engagement, or otherwise known as the work requirements. So let's talk about eligibility determinations. This is the process by which the state Medicaid determines that those who are enrolled or are going to be applying for Medicaid actually qualify. Typically, for the expanded population, the eligibility determinations occurred on a yearly cadence, so every 12 months. Under OBA, that redetermination period is now going to switch to every 6 months instead. This is specifically for the adult expansion population. It doesn't necessarily apply to those who are not on Medicaid expansion or who fall under a different waiver program. Another requirement under the eligibility determination that I found interesting is they now are going to be implementing a quarterly screening to review for deceased enrollees, basically a quarterly check-in. Hey, are you dead? No? Okay, great. They're going to be doing this for both enrollees and for deceased providers starting for enrollees January 1, 2027, and then in January of 2028, they will be doing it for providers as well. This 6-month eligibility determination is going to play a huge part in what we see for the community engagement process as well. There are a number of ways to interpret the eligibility determination and the scheduling thereof. So typically, once you enroll and are deemed eligible for Medicaid, let's say January 1, 2025, you enrolled, your next 12-month eligibility determination meeting would be January 1, 2026, so 12 months after. The states have some flexibility in determining that cadence when you're shifting from a 12-month eligibility determination to a 6-month. And the feds allowed that flexibility in determining what it means for those eligibility redetermination interviews if they're scheduled on or after January 1 of 2027. The first way that you can interpret it is that if you are enrolled in 2026, that as long as you're given a 6-month window, your new eligibility determination interview will be scheduled at least 6 months after that time. So in the example that I provided here, if you enroll on November 1, 2026, under the 12-month eligibility redetermination, your next interview would be on November 1, 2027. But under this new schedule, and if the state chooses option number 1, your next interview would be May 1st of 2027. It can't be scheduled sooner than that. Every enrollee must be provided at least 6 months of eligibility before their redetermination is scheduled. And so if your determination would have come up May 1st of 2026, you could be scheduled for a new eligibility determination as early as January 4th of 2027. The next option is to transition the beneficiaries to 6-month renewal periods at the next scheduled interview. So if the state chooses option 2, again, let's assume November 1, 2026 initial application and determination of eligibility, the state can wait until after your next redetermination hearing or appointment, which would occur on November 1, 2027, and then move you to the 6-month redetermination schedule. So then your next 6 month would occur on May 1st, 2028. I know that's somewhat complicated, but it does make a difference for those enrollees who are going to be faced with, their compliance requirements and the cadence at which they're required to renew. I suspect that Idaho will choose option 1. I haven't seen any specific confirmation of that other than what we saw in House Bill 913 of this year, and we'll talk about that in a second. But it seems like our legislature is highly committed to this 6-month window and implementing the work requirements as soon as possible. So I suspect that in Idaho, we will select option 1, which means that the 6-month cadence will begin as soon as possible. There's some special considerations that we don't have answers for, at least I haven't seen answers for, specifically around households who might have different renewal schedules. If you have a household where one individual is eligible on May 1st and the next individual is eligible come November 1st, the states can't shorten or extend the enrollee's eligibility period, but in that process of collecting information for those two individuals, it is possible that the state might collect information that indicates one person may or may not qualify any longer. So we're going to see some issues, and I'm not sure how they will be resolved. We will also see issues when individuals move between eligibility groups. So if you were previously eligible for the 12-month renewal, so for instance, somebody who is on a waiver, you lose eligibility for some reason and now have to renew under a 6-month schedule, the state has to provide you additional notice. They have to make sure that you're aware of the change, and you have to provide enough information to demonstrate your eligibility under the 6-month schedule. Also, if you were previously excluded from the community engagement, which we'll talk about later, during that 6-month renewal period, but you lose that, you have to monitor during your 6-month eligibility window to determine whether or not you need to comply with the work requirements at a later date. Also, these renewal requirements that we're talking about, they apply to, and I'm going to use this colloquial term, the adult expansion group. There's a more technical term, but it doesn't help anyone to really memorize that. And even if the community engagement exceptions do apply, so if you are exempt from having to meet the community engagement requirements, you still have to apply by the 6-month eligibility window requirement. The next element that is going to be impacting our Medicaid population is cost sharing. Now, cost sharing has been around for a while. There are certainly some states who have implemented this differently than Idaho, but essentially what this means is that for those expansion population adults, they will be facing a co-share for treatment. There are some services that will be excluded from this cost sharing requirement, specifically primary care, preventative care, mental health services, those services relating to substance use disorders. There's certainly populations that will be exempt from this co-share: children under 18, pregnancy-related services, and finally, there are service providers who will be excluded from seeking the cost share. And those are the federally qualified health centers that I mentioned at the beginning of our talk, rural health clinics, and certified community and behavioral health clinics. So those specific providers will not be required to pursue the cost share from their Medicaid patients. So the cost share requires that no more than $35 per visit and per item of service be charged. Services can't be denied if participants can't pay under OA. And I'm going to put a big asterisk there, and we'll come back to this later in our presentation, assuming that we have time. But Idaho would propose a different model, and that different model would require that eligibility be tied to the ability to pay for your co-share requirement. The other thing is that service providers can deny treatment under OBA if the individual can't pay, but they won't be disenrolled from Medicaid for non-payment. And finally, there's a cap for the cost sharing, which means the total pocket family limit is 5% of the family income. And once you've reached that, the cost share won't apply. The next element that applies to that OBA changed for Medicaid is this retroactive application. So previously under, let's say pre-OBA, if you applied for Medicaid and you were determined eligible, the state would be able to look back 3 months or 90 days to determine if you obtained any Medicaid eligible services while you were eligible. That look back period is now limited significantly. And it's limited in 2 ways. One, For the expansion population, it's limited to 30 days. And for the non-expansion population, it's limited to 60 days. So there's a 30-day and a 60-day look back period. But the bigger question is this language under the OBA, the changes to OBA, requires that the individual be eligible for Medicaid in the month that you're looking back to. So if you have someone who's applying for Medicaid on, let's say, May 1st, 2027, and for the last 3 months in Idaho, 3 months is kind of the key term right now, they hadn't met their community service or their community engagement requirement in the month of April. The state would look back to that month, ask them to prove that they are eligible for Medicaid, and if they can't meet that community eligibility requirement, then services will be denied. So the effectiveness of this retroactive application, I think, will severely be limited based on that requirement, and it will change the way that care is compensated in Medicaid or for Medicaid eligibility, specifically in Idaho. Okay, so let's talk about the big picture here, the big one that we want to talk about. Community engagement, otherwise known as the work requirements. This is going to be maybe the largest change to Medicaid that we've seen. And it applies to all states who have accepted coverage under the expansion population, so basically expanded Medicaid. In most cases, this coverage or this requirement will begin on January 1 of 2027, but if states want to, they can begin sooner. The downside is the state has to be ready, and this is going to be a huge administrative lift. So I can't foresee states really being ready to implement it sooner, but we have had overachievers in the past. I wouldn't be surprised. And also, the interesting thing about OBA is the feds recognize that some states would want to be creative in avoiding having to enforce the community engagement. So they specifically said that you can't waive the community engagement under a Section 115 waiver, demonstration waiver. So, and if for those of you who don't know what a demonstration waiver is under Section 115, it essentially is a way for states to say, hey, we want to change the way we operate Medicaid. They supply a state plan amendment to the feds. The feds review it. They make some determinations whether or not it's going to be cost neutral, whether it's going to actually provide benefit, and then they let the state try it. Or not. And sometimes they just sit on those state plan amendments for a very long time. Anyway, the feds have said that you can't waive the community engagement under one of these waivers, so you can't get away from it. So let's talk about some of the key requirements. This applies to applicable individuals, specifically expansion adult populations, those who are eligible to enroll or enrolled in the Section 115 demonstration waiver, so long as that demonstration waiver provides the minimum essential coverage to those who are not pregnant, not disabled, not dual eligible population, not otherwise enrolled in traditional Medicaid, and not below the age of 19 and or over the age of 64. What does that mean? So if you have a state demonstration waiver that essentially provides the minimum essential coverage, so you're not talking about traditional Medicaid, we're not talking about the aged and disabled waiver, we're not talking about the developmental disability waiver, but you have some other demonstration project that basically provides your minimum essential coverage, then it will apply to those individuals on that waiver program, as long as they are over the age of 18 and under the age of 65. All right, so let's talk about community engagement. What do we mean by that? So there's the working requirement, or an element, and let me back up. There's a number of ways that you can satisfy your community engagement requirement. One is to work at least 80 hours per month. Another is to complete at least 80 hours of community service per month. Another is to participate in a work program for at least 80 hours per month. You can be enrolled in an educational program at least half time, or any combination of the above. So if you volunteer for 40 hours and work for 40 hours, that would satisfy. If you participate in a work program for 20 hours and you work for 60 hours, that would satisfy. But you essentially need to demonstrate 20 hours of work per week per month in order to satisfy the community engagement. Now, there's another way to satisfy this as well, beyond just the working element, and that is to demonstrate monthly income. So if you are able to demonstrate that you make at least $580 per month, which is a factor of the current federal minimum wage times 80, then you would satisfy the community engagement requirement as well. Another way to do this, if you're a seasonal worker, you can look at the last 6 months of your monthly income and demonstrate that the average for the 6 months is not less than $580 per month. So that's pretty confusing, or it could be pretty confusing. Just to give some context to those numbers, let's say that if your income was $1,000 in month one, again, let's talk about the seasonal workers. $300 in month two, $400 in month three, $2,000 in month four, $300 in month five, and $100 in month six. You would average all of these monthly incomes over the 6 months. And if, for those of you who are following along in this example, that averages about to $683 per month, which would satisfy this work requirement. Now, the interesting thing is just recall that if you're on Medicaid expansion, that means that your average income is 138% or less of the federal poverty level. For those of for a single person in 2026, that's roughly the federal poverty level is roughly $16,000. It's $15,960. For a family of two, it's $21,000 and $21,640. And for the federal poverty level, the 138% of that would be roughly $22,000 for that single person. So you're not making a lot. It certainly wouldn't be enough to pay for your average living expenses, I would think, in this day and age, given the costs and the inflation that we've seen over the last few years. So I don't know. I'm going to censor my words right there. Okay. So let's talk about some of the definitions, because I think this is where we are going to see, we're going to talk about some of these definitions specifically regarding work program, what it means for community service, and then what it means for to be in an educational program. I think if I'm reading the tea leaves, those are some areas where we will see some requirement from the state or the feds to expand on the definitions. Currently, the feds have defined work programs to include the following: the federally authorized workforce or trade adjustment programs, state and local employment and training programs, employment and training programs for veterans operated by the Department of Labor or Veterans Affairs, and then qualifying workforce partnerships. Educational programs mean an institution of higher education under Section 101 of the Higher Education Act of 1965, or trade school, career, or technical education in under that definition. So it seems to me like for the work program and educational program requirements, the feds have provided very bright lines to satisfy or determine whether or not someone has satisfied those elements. Where I am getting a little nervous is with regard to community service. I can't find a definition under the OBA, what it means to have community service or what it means to participate in community service. While we generally understand community service to mean unpaid service performed for the benefit of the community through public or non-profit organizations or a governmental entity, there's a lot of flexibility in that determination or in that definition. And I suspect that if someone who is enrolled in Medicaid realizes that they want to participate, they could unwittingly or unknowingly participate in some form of community service that the state or the feds later determine should not satisfy this requirement because it doesn't meet a specific definition or it doesn't meet a specific requirement, which we don't have yet. I guess if I'm thinking about a hypothetical, I know many communities have community gardens. And if they need volunteers to help participate in construction and maintenance of this community garden, the profits and the proceeds of which are to benefit either the community at large or for unmet needs. Reading the comments, sorry, it is somewhat terrifying. If I were to participate in helping that community garden succeed for 20 hours a week, there is a chance that at the end of my eligibility determination, because that specific community garden didn't have a 501(c)(3) designation, it didn't qualify as a nonprofit, and my work or participation wouldn't qualify. I don't know. Again, we just lack the specific guardrails around this definition to give me peace of mind on how I can help my clients know how to educate their patients. So moving on, there are certain categories of individuals who will qualify as exempted or be excluded from the community engagement. Those are former foster care children within a specific time frame after that, certain American Indians and American or Alaskan Natives, parents, caretaker relatives, guardians, family of caregivers of children under the age of 14, or disabled individuals. So if you're a parent, you're a grandparent, you're an aunt, uncle, brother, sister, et cetera, and you were caring for a child under the age of 14, you would not be required to perform under the community engagement. Or if you are a parent of a disabled individual and their care is, you are in charge of their care, you would likely fall under this exclusion. Veterans with total disability ratings are excluded from the community engagement, and medically frail individuals, those with special medical needs. The feds have defined this as blind, disabled. I'm going to come back to the question. Blind, disabled, have substance use disorders, physical, intellectual, or developmental disabilities that impairs the ability to perform one or more activities of daily living, and individuals with serious or complex medical conditions. And I am actually not sure why we have identified certain American Indians. That's just what the statute says. I suspect that it has to do with some other federal legislations and the treaties that the feds have. I'm going to reserve judgment or saying anything else because I don't want to say something out of school. Where I think, looking at the tea leaves, where I think there is room for complications in administering the community engagements is with this definition of the medically frail. Oops, go back. Medically frail, those individuals with special needs, and those individuals who have substance use disorders. My question to those who are implementing this is how will we determine medical frailty, and what information will the state be allowed to use in determining whether or not someone meets this condition? And there's a high chance that if you have someone who has a serious mental illness, that they may not understand how to appropriately advocate for themselves such that the information is given to the right person at the right time. Now, under the Fed's anticipation on how, and we'll talk about this in a second, on how individuals will present this information, how the states will get information about an individual's eligibility. Idaho has a different method, and Idaho's method is where I think we could have more complications, which will lead to a higher administrative burden, both for enrollees as well as the state. So we'll talk about this in context of House Bill 345 towards the end of our presentation. But just know that this particular population, the medically frail, those with special medical needs, could have a higher burden than OBA is intending right now. And I'm realizing, okay, I have plenty of time. I have 30 minutes. Yeah, it's terrifying. Okay. Other exclusions: individuals who currently satisfy the temporary assistance for needy families, because under TANF, there is already a work requirement. So if you satisfy under TANF, you don't also have to satisfy for the Medicaid community engagement. If you get assistance under SNAP benefits, the Supplemental Nutritional Assistance Program, and are not exempt under SNAP. Inmates of public institutions. So if you're an inmate, you don't have to satisfy the community engagement, which is probably a good thing. And individuals who were an individual who was an inmate within the last 3 months, ending on the first month in which the individual is otherwise subject to the community engagement requirements, they are also not required to perform. Okay, more exclusions. If you are participating in certain substance use disorder treatments or rehabilitation program, you don't have to demonstrate work requirements. If you're under the age of 19, if you are entitled to also be enrolled in Medicare or Medicaid Part A or B. So otherwise, we call this dual enrolled. And if you are mandatorily categorically needy, you are also not required to perform community engagement. And then pregnant individuals or individuals who are entitled to postpartum medical assistance, we would typically see this under the WIC program. You would also not have to engage in community engagement. So the state has the option to allow short-term hardship exceptions. So if you have been deemed, or sorry, if you have been either in inpatient hospital services, or if you were receiving nursing facility level care services and ICFID, which stands for an intellectual care facility for those who are intellectually disabled, or if you were at an inpatient or psychiatric hospital services, you can apply for a short-term hardship if the state allows it, and not have to abide by or perform under the community work requirement or the community engagement. Also, if you, another option for the state, I have to preface this with these are all states or options that the state can implement. Notably, there is that this is not a given. This is not like an absolute, every state is going to be providing these short-term hardship exceptions. So if there was an emergency disaster declared in a particular county, or if a particular county has unreasonably high unemployment rates, either determined by 8% above or 8% at 8% or 1.5% higher than the national average, whichever is the lesser of, then the state could use that as a determinant for declaring a short-term hardship. And also, if you as an enrollee have to travel for specific serious care for a complex medical condition that's not available in your community, then it is possible to apply for and obtain a short-term hardship exception, again, if the state allows it. Okay, so I'm looking at the chats. There was a question, are there any clear definitions for family caregivers of children? Some grandparents do this part-time, for example. I don't know that we've seen any specific definitions on that, just simply that if you are a caregiver, and I'm making some assumptions here that if you're just looking after a grandchild part-time on behalf of a parent, and you're not their legal guardian, then that might not meet the exception. I'm not quite sure. We would hope that the rules either promulgated by the feds or the state would clarify what they mean and how much how many of the bundle of parental rights you have to have or obtain in order to make that claim. Okay. So we talked about short-term hardship assumptions. Okay, the next big thing, and one that will apply to Idaho hugely, is this review period. So for those who are going to be applying for Medicaid, you have to demonstrate community engagement for, and this is where states have options, for 1 month or 2 months or 3 months prior to the month of application. States can choose if they want the 1 month, 2 month, or 3 month option. Idaho, through House Bill 913, and I mentioned this at the start of our talk today, has determined that the 3 month option is the best option for Idaho. So no later than December 31st of 2026, the Idaho Department of Health and Welfare, otherwise known as the department, has to implement the community engagement requirements. The look back period under Idaho's House Bill 913 is 3 months. And as of December 31st, 2026, the department is directed to disenroll those individuals who are currently enrolled and unable to demonstrate compliance. So let's talk about this. What does this mean? What is the big impact? This means that starting October 1st of 2026, for those who are currently on Medicaid, they have to start complying with community engagement. despite the fact that this bill or OBA was not directed to begin until January 1 of 2027. Because of the 3-month look back period, those individuals who are on Medicaid have to start complying on October 1, 2026. And I know the department is doing its best. And I know that many advocates are going to be starting the outreach program. We'll talk about outreach in a second. But our best case scenario is if everyone who is on Medicaid knows by October 1st of 2026 that they have to begin complying with community engagement. Okay, so when will these reviews be conducted? The OBA requires them to be performed at application, also at renewals, so that 6-month renewal time period that we talked about at the very beginning, and then more frequently if the state elects. So even though OBA says 6 months, states can conduct the community engagement reviews more frequently if they so desire. Okay, under OBA, the feds anticipate that states will use reliable data sources to determine eligibility. They'll look at labor reports from the Department of Labor. They'll look at prior Medicaid encounter data, Medicaid provider payments, any other data sources regarding higher education enrollment, job training participations. They're encouraged to seek these outside sources to determine eligibility rather than trying to have the individual make these direct reports themselves. Under the OBA language, states may not request additional information from the enrollee unless it is unable to establish that the individual complied with community engagement requirements using these reliable sources. This is where Idaho diverges in one very significant way. And in 2025, and I have a slide for this and we'll talk about it in a minute, the House Bill 345 was enacted. And the state legislature specifically directed the department not to use pre-populated forms, which is essentially what this process does. We, under OBA, they would take all of this additional information, populate a form, send it to the enrollee and say, is this accurate? But under House Bill 345, the state legislature has directed the department not to perform reviews this way. If an individual, and I'm sorry, I'm skipping topics, it's just the way that my brain kind of worked when I was trying to dissect all of this. So let's just say for a minute that an individual cannot determine, or the state cannot determine that the individual met the community work requirements. Under OBA, there are fair hearing, there's a process, there's due process. Every state administrative agency is required to provide due process before taking away a benefit, which in Medicaid is a benefit. So the feds directed that the states must first provide the individual notice of the determination. Basically, we find you not eligible, or we find that you didn't satisfy the work requirements. And they then provide the individual 30 days for the individual to comply or to show that they meet an exception. So again, if you're pregnant, if you're in school, or if you're a caregiver, et cetera. The notice from the state has to inform the individual on how to comply or how to show that the exemption is applicable. And that the individual, the feds also determined or mandated that the individual not be disenrolled or the application be denied and during that 30-day period. It also had that notice from the state also has to show or inform the individual on how to reapply in the event of a disenrollment or if the application is denied. So if the individual is a current enrollee, then coverage must continue for that 30-day period. If no satisfactory information is received or obtained by the state after that 30-day period, then the state has to decide on the individual's eligibility. They have to provide notice to the individual on the denial or on the re-enrollment or disenrollment. And then they have to provide the individual the right to a fair hearing, which is, it's outlined as a very specific requirement. The individual has the opportunity before a hearing officer to demonstrate why they should be entitled to receive the Medicaid so why they're otherwise eligible. So let's talk about outreach. So what is the good if we have this new process, but then no one knows or understands these requirements? What is the what would happen? Well, essentially everyone would be disenrolled because no one would understand their obligation. The feds knew this. They had some good case studies as to what happens when we don't do appropriate outreach. And so they required in OBA very specific mandates to the state on how to conduct this outreach. The first is that they have to use at least two different forms of outreach, either regular and regular mail, and then electronic mail or text, telephone, website, or other electronic means. The outreach also has to be very clear on how to comply with the community engagements requirements, including the definition of what is an applicable individual and those exceptions that might apply. This is where our history tells us, at least from our case study, and we'll talk about it. This didn't happen in the past, at least in the one example that we'll discuss. And the outcome or the natural consequence of that is many people didn't know that it applied to them. And so, or they didn't know that it didn't apply to them, which led to a huge administrative burden. And the consequences of that was basically a huge, well, a percentage of the population losing enrollment. So the state must also notify and educate the enrollees the consequences of noncompliance, and then also how to report, how to make that change of status report. And the timeline of this. So again, when we talked earlier, the states have the option for a 1 month, 2 month, or 3 month look back period for the community engagement. For those states that are choosing the 1 month time period, they have to begin their outreach in September of 2026. For those months who are showing or requiring a 2 month community engagement prior to application, they have to begin their outreach in August of 2026. And for those like Idaho, and I put that nice little golden arrow there at the bottom, who are choosing a 3 month look back period for the community engagement, they need to begin their outreach in July of 2026 to ensure compliance. So we know that the department is already gearing up for this. They want to make sure that their enrollees are aware of their compliance requirements, but it is going to be a big lift. And so we in the community, the clients that we advise, we encourage and support earlier the better, and providing opportunities for individuals to ask questions will be incredibly helpful. So those are the big broad brush strokes of the changes to Medicaid under OBA. I want to give you a different time. And by the way, this timeline for outreach, this is what CMS has provided. They actually have some pretty decent informational packets out there. They could still define a few more terms as we talked about. And I look forward to the rules and regulations that will be coming. For the rest of the requirements, this is the timeline. This is what we're looking for. So in 2026, we will see states beginning outreach. I put Idaho must issue temporary rules. They don't have to. They don't have to do anything. I would hope that they would issue temporary rules to help this process along. Starting January 1 of 2027, we see that the work requirements community engagement will start. Along with that retroactive coverage that we talked about, that reduction in the coverage, that will begin January of 2027, along with the semi-annual redeterminations, so the 6 month redeterminations. These other things we didn't really talk about today. There's just so much in OBA that we will not have time for, but they are out there, and they will be impacting both Medicaid and the health landscape in Idaho and nationwide as we progress. So even though, the cost sharing will start in 2028. So beyond what we talked about, there are other mechanics at play that will change our landscape, and it's just good to have that awareness. I mentioned our historical examples, and I mentioned another state back in 2018, it was Arkansas, who implemented community engagement. And Arkansas has somewhat been of the litmus test on whether or not work requirements will be effective. Arkansas is somewhat of a limited example because of how poorly it went down. They um, they mm, they limited the outreach. They didn't provide effective notice. They didn't describe who it would apply to and who was exempt from it. They provided very uh, hard or difficult obstacles for making the work requirement reporting, such as a website that was only effective from 9 to 5 during the day, or a phone service that was only available during working hours. So for those who work during those hours, or for those who don't have an internet connection, or for those who don't have a cell phone, it made it really impossible, if not, challenging at the very least, to make the required monthly reporting on their work compliance. Studies have shown that 90% of the individuals who were on the Arkansas Medicaid expansion program were satisfying the work requirements already. They just couldn't meet the reporting requirements. And in the end, over 18,000 individuals lost coverage. Um, the real kicker, and the part where I think whoever is on the advocacy panel in making these decisions, I would want them to take a deeper look into this, is that Arkansas can't prove any significant impact on increased employment for this population, which is really the goal of having work requirements. So with that, we look at what happened in Arkansas, and I know the feds looked at what happened in Arkansas, and they tried to alleviate some of these obstacles by having the required intense outreach, by having the ability to communicate in more than one way. I see these efforts and these attempts to try to change those things, which is great. I still think that the ultimate determination, though, is that not having any impact on employment rates might be what we see in this next year or so. I see there's a flurry of questions. Okay, you guys are taking care of it. You're good. The next example that we know here in Idaho about what happens when we have huge waves of administrative burdens on enrollment is the Medicaid unwinding in 2023. So during the COVID era, there were specific protections on those who could be removed from Medicaid. Prior to that, this is in 2023. So in March of 2023, Idaho had approximately 460,000 Idahoans on Medicaid, both traditional and expansion population. And then when the COVID era protections ended, and the state was required to remove those individuals from Medicaid who were no longer eligible, we saw a drop of approximately 130,000, 130,000. So that number dropped to 314,000. So it's approximately a 31% drop. But by March of 2024, we see that enrollment increased again to around 334,000, which could indicate some level of churn, meaning that those individuals who were dropped through the Medicaid unwinding could have been dropped inappropriately or unnecessarily and then had to reapply. So there is a chance of that happening again here in this context of the community engagement. For those who might not meet it in 1 month, they can reapply and hopefully meet the requirements the next month. There's also a chance that those individuals might be unenrolled improperly, and then be forced to or require the state to re-enroll them after demonstrating compliance. All of this means that the state has a huge administrative lift. Where we previously had a 12-month redetermination period, we're now doubling that to 6 months. We know that the state already has administrative burdens on workforce. So, ideally, we would like to see that more FTPs, full-time positions, were assigned to the state to help with their compliance requirements, to help ease the burden for enrollees. TBD on what actually unfolds. And we mentioned House Bill 345, and I'm trying to be sensitive to time. But House Bill 345 and OBA has some disconnect, and I don't believe that this disconnect was really answered well in this last legislative session. And there's still a chance that the department will be required to submit a state plan amendment to abide by House Bill 345. So specifically where we see some disconnect, that parental caretaker exemption under House Bill 345 limits the age of the children to the age of 6, whereas under OBA, the child's age is 14 or under, under the age of 14. Um, Idaho's vet definition of those who would be exempted from physical or mental disability are those they call it those who are physically or mentally unfit for employment, where OBA has a broader definition for those who are medically frail. Idaho specifically exempted those who are receiving unemployment and complying with work requirements under the unemployment program. And while the OBA does talk about work programs, it doesn't specifically talk about those on unemployment. And Idaho proposes that a person's eligibility would be conditioned on the cost sharing component, where OBA does not. OBA again says your eligibility is fine if you don't pay the cost sharing. It's just that the service provider can deny treatment. And lastly, and probably most importantly, is that Idaho would prohibit renewals based on automatically based on available information and pre-populated forms, where it seems like OBA does encourage that as an administrative efficiency. Don't know what exactly or how that is going to unfold, or how that bridge is going to be crossed, but we need some efficiencies in this program, and we need to be able to have individuals look at or have other ways of having information supplied to the state beyond what they self-report. Some other variables that we see is or that we will be seeing in Idaho is the managed care model. It is coming. We originally thought that it would be coming in 2027, then 2028, 2029, and now we know it's going to be delayed until 2030. When managed care comes on board, those individuals who are currently enrolled will see a change. They will likely not see a change to their care necessarily, or their covered services necessarily, but they could see changes into enrolled providers. And yeah, we also know that under the ACA exchange, the subsidies that were provided, those expanded subsidies, had not been renewed. So those who were on ACA, we might see some changes to Medicaid enrollment because of lack of coverage. And then lastly, we don't know what the federal regulations or the state rules will ultimately look like. And we hope that the states and the feds provide enough guidance and clarity so that individuals understand their compliance requirements. But because we haven't seen them yet, it's a big question mark. Our estimated impacts right now is that under these requirements, 20 to 34,000 will lose coverage in Idaho. We will also see that providers face potential burdens. There is going to be uncompensated care. And for those providers who rely significantly on Medicaid coverage or Medicaid populations, they're going to have to make some decisions. Do they increase their bottom line to account for charitable care or charitable services, or do they tell this population that they can't serve them, which feels difficult from a healthcare provider's perspective who is committed to their patient's health. We will also likely see some strain on our healthcare systems, like the emergency room or hospital systems who are required to provide health stabilizing care to those individuals, even if they don't have the ability to pay. And that ultimately those costs are transferred down to our community. They impact our insurance coverage. It's a trickle down. And then lastly, what we're going to see is that for those enrollees who are in the expanded population, their cost of care is going to increase. I appreciate that they're limiting the cost sharing requirement to 5% of the household income, but that's still 5% of the household income on a very tight budget. And if you are someone who has a chronic condition that is not exempted, or is the care for which is not exempted, that can add up. And the difference in paying $700 in health-related services for someone who is only making, let's say, $17,000 a year, I mean, that can make or break a budget, which means that people will go without care. And so that when they do turn up into the emergency room and their care has now been, mixed or delayed such that their one complex medical condition now has comorbidities. And so instead of treating that one that could be satisfied with preventative care, the cost of care could increase. Um, and then we talked about the state administrative burden that this is going to present for Idaho, the department in general, and then just the churn of patients. Before I go to my closing statements, let's see if there's any questions that I missed. Yeah. So there's a comment in there about public sector participation, and I absolutely 100% agree. Our clients that we advise, those clients that we partner with, we are having the conversations about how to educate their population, how to ensure that those participants know their requirements. I know that our community health workers within those population and provider groups, they are gearing up for it. I think that there's also room within the market for emerging AI growth. I suspect that we will see vendors who will partner alongside with provider groups to ensure that their patients have the information that they need so that they can be successful. And I highly want to encourage collaborative partnership with the department and with our state legislature to drive innovation so that the information that they have is appropriate, up to date, and supports this vulnerable population. And then lastly, just advocate. There's still time for change. There's still issues that I think are unsettled or not decided in Idaho. One specifically is regarding the cost for the cost share. The federal under OBA, the cost share has to be less than $35, but it doesn't mean it has to be more than X amount. So if there is a way that Idaho can partner with its healthcare providers to determine what would be an appropriate share, that would be excellent. And then just for partnering and participating in the negotiated rulemaking. I know that the department listens. I know that the legislature listens. Now, whether it makes a difference, TBD, but I do know that they listen and they want to hear from their constituents about this very important topic. Okay, I have 2 minutes left. I would be open to any other questions. I know that was a lot of information, and I hope it was helpful. This is again coming from the perspective of a lawyer, so it's pretty meaty because we just live in code. If not, Dr. Banks, I really appreciate the time and the opportunity to speak with your community.
Thank you, Chelsea. We're the ones who are indebted. I mean, right up to the tail end of time here. Not necessarily a question, but just a comment / question here. You did a great job of outlining the requirements that are put on individuals here. But it takes two to tango, right? And just based upon your expertise, what I noticed is the perhaps room for the role of employers in this aspect. I'm just imagining individuals, residing in rural settings, and we have a large employer there who relocates, right? All of a sudden, there's an absence of employment opportunities outside of rural settings, employment where, a number of jobs are being lost, either outsourced or lost to AI. And so there are those opportunities, they're lost. And so is there any mention or talk of employers if you're saying, hey, X% of individuals on Medicaid, you're going to be required to work now? Are there opportunities to say for employers, hey, you're going to have to interview X amount of individuals who are on the Medicaid? And I was, as I was thinking about answering that question, it's like, well, there are reasons why certain individuals are unemployed. You mentioned the income thresholds for Medicaid, less $20,000, less than that for individuals. And for employers, with those, is there necessarily cultural fit, individuals who are employed making 50, 60, 70, 150, 120,000, those individuals look, feel, behave, their lived experiences are very, very different from individuals who, perhaps making $20,000 a year for generations. There was a lot there, but just, I don't think we saw employers, we saw employees a lot, right? But employers there, I don't know if we saw that.
Yeah, I suspect that the culture in Idaho is such that they would not mandate employers to take on a specific population of individuals. I suspect that the very capitalistic mindset is if you want to be an employee, you have to be qualified for the role or the position that is being offered. And the employer gets to make merit-based decisions on who they want to employ or not. I do see the point, though, that those advocacy groups could be partnering with certain employers to ensure that employment is available. I think that that's an effort that hasn't been discussed, at least in the conversations I've been in. Also, in terms of community service, I know that there are plenty of not-for-profit organizations who would adore having volunteers who could participate in programs to help benefit their community. I think that there is going to be need to connect the two, and advocacy groups could be that channel that connects employers with participants or enrollees, or volunteer groups with enrollees. And I'm sure there are efforts out there that are already being conducted, and it's possible that I'm just not at that table or in those conversations. But I do see your point.
Elsie, thank you. And thank you to all of those who are in attendance. We're right at the top of the hour. Thank you again, and we'll be seeing you next time. Thank you all.
Thank you.
Okay. Bye.